in 40% of patients. Most common location was trigonal in 45%, followed closely by supratrigonal location. Most of the fistulae were primary. Ureteric catheterization or DJ stenting was done in 3 patients in the initial phase of the study, in whom the fistula was close to the ureteric orifice. Later on, in those cases also, the ureteric catheterization was not done. Preperitoneal fat or peritoneum was most commonly used as interposition tissue, followed by Marsh's flap. In 9%, no interposition tissue was placed. Most of the fistula were single in 88% of patients. On comparing our result with the minimally invasive cohort in the review, mean operative time in our series was 63 minutes, and in their series it was 161 minutes. The difference was statistically significant. Estimated blood loss was 48 minutes in our series and 103 minutes in their series, which was also 103 ml in their series, which was also statistically significant. Post-operative hospital stay was 3 days in our study and 3.5 days in the minimally invasive cohort, and the difference was significant. Success rate in our study was 99.5% and 96.5% in laparoscopy or robotic technique. Our follow-up was 6 to 112 months, and the follow-up in the reported minimally invasive cohort was 1 to 20 months. To conclude, the excellent outcome along with minimal morbidity of transvaginal VVF repair makes it comparable to literature reported outcomes by minimally invasive approaches in simple VVF. However, transvaginal approach performs better in terms of resource utilization, particularly in low resource settings. These are my references. This is the second one is the study from which I had compared our findings. Thank you.
Dr. Naveen,
Yes.
what time you prefer for the surgery, immediate or after some duration? And
in
why?
our series, we performed all surgeries after an interval of 8 to 12 weeks.
Reason?
Reason to let the edema to subside and to let the inflammation and edema to subside so that the suture holding capacity of the tissue is optimized.
And what about infection?
Yes.
Infection? What
Yes.
about infection?
No, there is no infection. We don't let the catheter stay for more than 6 weeks. We let the urine drain out through the vagina.
Okay, fine. Harpreet.
Yeah. So Naveen, this was a study done in SGPGI during your.
Yeah, I'm still in SGPGI. I have completed my MCH, but they have extended our tenure due to COVID.
Okay. Right. Naveen, so you feel that this is a good procedure for a simple fistula, right?
Yes, sure.
So I see most of their studies are mainly trigonal and a little bit supratrigonal also, but
40% were supratrigonal.
Right.
Okay, Dr. Naveen, now
what is the message you want to give?
I want to give that for simple jacovaginal fistula, there is a significant difference in the cost between the transvaginal repair and the laparoscopic or robotic transabdominal repair. So in our country, where the patient has already exhausted his resources in the primary gynecological surgery, he doesn't have money, and also the sophisticated instruments are not available easily. Transvaginal repair is a very good approach in simple VVF.
Only one thing, one comment, if chairpersons allow me, I want to make one comment. You have told me this was your mainly post-hysterectomy fistula.
Yeah, post-hysterectomy and post-cesarean, because the obstructed labor fistula were very rare, and also invariably all of them involved either the bladder neck or the urethra. So they come in the definition of complex fistula, and they were not included in this.
That's the only thing I wanted on. All right, carry on.
Dr. Naveen, can you present the next paper of yours, poster of yours?
Yeah. So the topic is the role of FDG PET-CT in evaluation of response to systemic therapy for advanced renal cell carcinoma, dissenting view and evidence. Targeted therapies for metastatic RCC are more cytostatic than cytotoxic. So they lead to tumor stabilization rather than regression. Rather, they may also initially lead to an increase in the size of tumor called pseudoprogression in up to 20% of cases. This makes RECIST criteria based on CT inadequate to discriminate patients with early response or progression. Often the size of the lesion may take time to respond and metabolic activity changes first, which is detected by the PET scan. The primary objective of our study was to evaluate the role of FDG PET-CT in comparison, which is the present standard of care in the evaluation of response to systemic therapy in patients with metastatic RCC on systemic therapy. So our hypothesis was physiological expression of FDG in kidney makes it unreliable for detection of kidney cancer. However, patients for other metastatic sites, we can see in the photograph that after therapy, the metabolic activity has decreased significantly in the metastatic lesions. However, the size has remained the same. So we conducted a prospective pilot study from June 2016 to January 2018 on 24 patients of metastatic RCC who were given systemic therapy. Before starting therapy, baseline PET-CT was done by acquiring whole body images from vertex to mid-thigh. 60 minutes after IV injection of 370 megabecquerel of 18-fluoro-FDG. A non-enhanced CT was also done simultaneously using a standardized protocol, and SUV max of all the metastatic sites was obtained. The PET-CT was repeated after 3 months of systemic therapy using the same protocol, and response evaluation was done using PERSIST criteria for PET and RECIST version 1.1 criteria for CT. Pre and post values were assessed using paired t-test and Wilcoxon sign ring test, and inter-rater agreement was done using Cohen's kappa. Coming to results, median age of the 24 patients was 49 years. Most common site of metastasis was 15 in lymph nodes, followed by bone, lung, liver, and surgical site. Most common therapy given was Pezopanib. We had to give different therapy according to the patient's preference and cost and the profile of the patient. So Pezopanib, then Sunitinib, Exitinib, or Everolimus was given. Most of the patients were male. Most common histology was clear cell RCC in 22 patients with Fuhrman grading of 2 in 17 patients. On stratifying by IMDC criteria, 16 patients fell in favorable risk, 5 in intermediate, and 3 in poor risk. Cytoreductive nephrectomy was done before systemic therapy in 21 patients, and 3 patients had their nephrectomy done before detection of metastasis. Follow-up of 16 months was there in median, and a total of 6 to 24 months. Coming to comparison of PET parameters, median SUV max was 8.1 at baseline with range of 2.2 to 19.4, and after 3 months it fell down to 6.1. The difference was statistically significant. On comparing RECIST and PERSIST criteria, 4 patients who had partial response in according to CT, they had out of these 1 patient fell into stable disease by PET criteria, and 3 patients progressed to progressive disease based on PET-CT. So 20 had similar response, and use of PET-CT led to upgradation from partial response to stable metabolic disease in 1 and progressive in 3, which led to a change in therapy for all 3 patients with upgradation to progressive metabolic disease. On applying univariate analysis for predictors of progression, there was no significant predictors of progression like age, drug used, or baseline SUV max. Median follow-up was of 16 months, out of which 2 mortalities were there, both in progressive metabolic disease group. This is the progression-free survival in different PERSIST response group. In the complete metabolic response, the survival is maintained. However, you can see in progressive metabolic disease, the survival is least. This is the overall progression-free survival. The limitations of our study were the small number of patients and short follow-up, because after 3 months, the patients were followed classically with CECT. To conclude, international guidelines state that PET-CT is not recommended in the management of RCC. While this may be true for primary RCC, it is an excellent tool for baseline and follow-up imaging in metastatic RCC, especially in post-nephrectomy setting, and larger studies are needed to validate the same. Thank you.
Harpreet, you asked the question. Harpreet,
Thanks. Thanks, Aman. Naveen, it's a very good, something different. I was going to ask you, since PET-CT is not recommended for actually for RCC, but the message, what's the message actually want to take us home from your this study?
Yes, practically, actually, we are doing PET-CT in most of the patients of metastatic RCC for follow-up.
One question I want to ask, that you showed some of the good response and some of the partial response. Are this patient whom you have shown a good response or stabilization, did they underwent cytoreductive therapy or nephrectomy before? And that correlation I'm not able to see in your study. Sorry.
Sir, in 21 patients, the nephrectomy was done after the detection of metastasis, but before the first PET CT and before the starting of therapy.
I didn't get you. Come again, Naveen.
Sir, in 21 patients,
The patients who has shown a good response,
sir,
have they underwent cytoreductive therapy or nephrectomy beforehand? That's what I want to ask.
so all patients had undergone cytoreductive nephrectomy beforehand. Either
All patients.
cytoreductive nephrectomy or nephrectomy prior to detection of metastasis as a curative therapy, curative procedure beforehand, before detection of metastasis.
So, how many percent of them stabilized? How many percent of them where you have seen the lesser lesion after starting this sonoperative?
Sir, means sir, 11 patients, one patient had complete response. 11 patient had partial response on the basis of CT criteria, but on the basis of PET, on applying PET scan, out of those 11, 4 were shifted to either progressive disease or a stable disease. So out of those 4, 1 had a stable disease and 3 had progressed on PET scan, but not on CT scan. On CT scan, they were showing as partial response.
So the message you want to convey is that the PET CT is more sensitive in a follow-up of a patient who is having a metastatic RC, right, Naveen?
Yes, sir, on therapy. Yes.
Wanted to tell everybody?
Yes, sir. Because it early detects the changes, the response of therapy.
Right. Thanks. I think we finished on time. Thanks to Sumit and who was the other person? Session.
Me.
And thank you.
Aman.
It's wonderful to interact and see you after a long time. And thank you, Arunima, for giving us this opportunity.
Sir, thank you very much for joining in, and we have got Dr. R.P. Srivastav who has joined in and Dr. Uday who have joined in this hall. So welcome, sir, both of you.
So Harpreet,
Good to hear.
you
Yes,
need
sir.
to remember Aman Srivastava and Sumit. You just can't say the other person.
No,
You
sir. I'm not asking. There is one girl.
No.
Sir, there is one girl who is moderate, who is along.
Sumega, Siva Sumega.
Arunima.
I was missing Sumega, not Aman.
Yeah.
Missing
Yes, I am
Sumega.
Who is the other girl?
Sumega. I was missing Sumega.
Arunima.
Yes, sir.
Oh, Sumegha.
Sumega. I wanted to convey thanks to Sumega.
Sumegha. So okay. Thanks.
And
that
I
I
also
teased
want to
you,
thank
so-
Dr. Aman Srivastav. Thank you
you
for
so much.
joining in for this session. It was a
Yeah, thank you
wonderful
so much.
session and very good
Yeah.
discussion.
Yeah. Thank you so much.
So what? Can I say something?
Yes, sir. Please go ahead.
Can I say something, Arunima?
Yes, sir. Please go ahead.
I'm the happiest person on this. I am the happiest person on this earth at this moment. Seeing the Jharkhand chapter in the activity under the dons like you and Harpreet, Sunil from Jamshedpur, Aman holding the flag from Bokaro, Sumit coming all the way joining from Sahibganj.
Thank
Sumit
you,
to
sir.
Sahib hai na? Ah.
Yes, sir.
Sumit has been
And
doing a
all
wonderful
these,
job.
Naveen and
Your
Naveen and Swamik, and I'm pretty sure Sumegha is going to fall in line with Arunima.
Yes, sir.
She is going
Yes,
to be
she
as
has got
brilliant
high
surgeon as
potentials.
Arunima.
Sir, a very good team has
So
been picked up.
very nice.
Very good
Carry on,
team,
dear.
sir. And Sumekha, Satvir, Sumit, Sushil, they have done a wonderful job, sir. And I think you'll see it through the conference.
So
Thank you, man.
let me enjoy.
Thank you, Srivastav sir, for your encouraging words, sir. Thank you, R.P. Srivastav sir, for your encouraging and motivating words, sir. Very nice to hear you from after a long time. Where are you? I'm not able to see you.
He
Good
has
evening,
not
Uday sir.
switched on his camera.
Okay, let me
Yeah,
start video.
Yeah.
Hi dear.
Please allow us your darshan. Thank you,
Hi
sir.
dear.
Good to see
I
you.
thought all your videos. Hi dear.
Good. Now we can
Same
see.
here.
Thanks
God
for your
bless you.
darshan, sir.
I'm taking the easy chair, I'm taking the easy chair, and I'm.
We can
Okay.
welcome Dr. Anwar Nizam
Anwar.
also. He has joined.
Okay.
Yes, sir. Yes, sir.
Anwar
Yes,
is
sir.
a ship bearer from Daltonganj, and
Okay,
he will
sir.
prove his worth. He
Okay,
is
sir.
another
Thank you,
worthy.
sir. Thank you, sir.
Right. Okay, good, very nice.
Okay. Okay.
So what next?
Madam will guide us for the next session to be taken over by
Yes, ma'am.
Dr. Sumit.
Yeah, I think Sumedha can just take over the next session and welcome our chairpersons and introduce them and then
Yes,
start
sir,
the
for the
session.
next session,
I would just want to thank Shobhik and Naveen for their presentation and Dr. Harpreet, who's also a part of the organizing committee, but I still thank him for doing the judging of this session, and Dr. Aman Srivastav. Thank you very much. We have got Dr. Uday Srivastav also with us in this hall. He is the chairman of the ASI Jharkhand chapter. Uday sir, do you want to say a few words and then we can start with the next session?
Yeah, we love to listen from Dr. Uday.
Hello.
Yes, sir, we can hear you.
I'm feeling very much happy, and we are starting our conference in a very good manner. And Dr. Harpreet is there, Dr. Armar is there, Sanjay is also there.
He has also joined.
Yes,
So
sir.
I hope the coming whole conference will be very good. Thank you.
Thank you, sir. Thank you.
Okay, sir.
Thank you very much.
Thanks.
Sumedha, please take over. Dr. Sanjay Kumar, welcome.
Yes, thank you.
Okay. Sumedha, please take over and start.
yes, good evening, everyone. And now we are going to start our next session, that is the poster session non-award category. I welcome on behalf of organizing committee our chairpersons, Dr. Anwar Nizam and Dr. Sanjay Kumar. Dr. Anwar Nizam is presently in Daltonganj running his own Lifeline Hospital, and he has special interest in minimal access surgery, including endourology, working in that field for many years. Welcome, sir. And we also
Thank you, ma'am.
welcome Dr. Sanjay Kumar from Palamu. He is presently assistant professor, Medini Roy Medical College and Hospital. And he is also a renowned surgeon there, and both our surgeons are very busy, so let's not wasting much of time. We are starting the session now. The speakers will be get 5 minutes
Okay.
presentation and 1 minute for
Discussion.
discussion. So
Okay.
now I welcome our first speaker, Dr. Loveleen Pandey. Now,
Pandey.
Loveleen, you can share your screen and start your presentation. Loveleen, and unmute yourself.
He has joined.
Loveleen, you can start your presentation. She is a DNB student from Bokaro.
Okay. Yeah. She is there.
You can start with Loveleen. We can see your screen, Loveleen. Just start your slideshow and start your presentation. Loveleen, start. What happened?
A minute is being lost.
Loveleen, are you there?
Yes.
Just start your presentation. Start your slideshow.
Start.
Sumegha, I'll just suggest let the chairpersons take over and let them
Okay,
monitor this part. You have introduced them, let them take over and monitor it.
Loveleen, you are not audible to us. Hello.
Hello.
Huh.
Hello.
It's your voice, Loveleen.
Am I audible, sir?
Yeah.
Yes, go ahead.
Now you are audible. Go ahead.
Good evening, everyone. I'm Dr. Loveleen Pandey, BNB resident, second year from Bokaro General Hospital. Here today I am to present my poster on the topic of diaphilia terata. It is extremely rare anatomical and congenital anomaly with the incidence of 1 in 5.5 million live births. and only few over 100 cases have been reported since the first case was reported in year 916. Uh, Coming to the case report, a 6-year-old male child was referred to us as a case of penile duplication with rectourethral fistula. Patient had complaints of pain abdomen with fever on and off since 3 months, and also complaints of unable to to urinate and
Sorry to disturb Loveleen, but your slides are not moving. Can you go to the slide presentation
Next slide.
and move your slides?
Yeah.
Yes, ma'am. Going back to the case report, the child has complaints of pain in abdomen with fever on and off since 3 months, and also complaints of unable to hold to urinate, and urine was consistently dribbling from both the penises. And while having loose stools, patient will also complain of passing stool and air to the lower urethra. On the examination of external genitalia, it revealed two completely separate penises of equal size, with each having normal urethral hiatus, intact scrotum with two normally descended testicles. Both the urethral orifices were catheterized and ended up in a single bladder. Child was born with imperforate anus, which was repaired at the time of birth in a remote setting where the rectourethral fistula was missed. Uh, uh, USG abdomen was done for this patient, which was suggestive of left hydronephrosis with the perinephric fluid and grossly distended urinary bladder with thickened trabeculated wall. In such cases, we need a few more investigations to come to the diagnosis or to confirm the diagnosis. Here, an external genital examination is very important, which will not only help us to classify the degree of duplication, but also assist in excision or reconstruction of the duplicate penis. Further, we can do USG or MRI to confirm the diagnosis. It detects the number of corpora cavernosa and spongiosum and their accompanying abnormalities. Apart from that, we can do erythrocystoscopy and erythrocystograph uh, and rectoscopy in our case. Coming to the discussion part, diaphilia is a quite rare condition. Every case is unique and presents with variety of extent of duplication and associate anomalies. Believed to arise from either separation of pubic tubercle, wherein the phallus will have one corporal body and urethra, or cleavage of pubic tubercle, wherein each phallus will have two corporal cavernous bodies and urethras. Uh, Schneider has
Dr.
classified.
Loveleen,
Yes, sir.
please shift to your next slide. It is not visible. Make it a full screen and just change your slides accordingly.
Full screen, sir.
The whole PowerPoint presentation is not visible. It is visible with your the side-wise slide also. So you can make it a full screen.
So your slide, your main slide has not moved from the case report beyond.
Yes,
so please keep shifting your slides so that whatever you are talking, it will be visible on a bigger screen.
Visible to us.
Did you get it, Loveleen? Yes. We are only seeing a written case report. No, is there a technical glitch?
Yes, sir.
Okay, go ahead. So you can select the slide which you want to show. What you are talking discussion, you can go and select discussion. Yes. I think that way, yes. Select the discussion.
Yeah.
Yes. You can keep selecting so that the next and next comes in. Yeah. Good.
Loveleen, kindly click on enable editing.
Yeah, if you click on enable editing, I think it is going to automatically start and you can go into slide presentation mode.
Yes, now you can
now go
make
to
it
the
full
slide.
screen.
Lower down, lower down, lower. Okay, fine.
Okay, learn
From
it,
current
learn
slide.
it, learn it. The discussion. You were on discussion.
Yes, sir.
Go and make it from current slide. Go to from current slide up in the ribbon.
Yes, ma'am.
Yeah. Yes. Okay. Okay, just make it okay. Yes.
sir. I'm done. Discussion part. Yeah, diaphasia is a quite rare condition. Every case is unique and presents with variety of extent of duplication and associated anomalies. It is believed to arise from either separation of pubic tubercle, where in each phallus will have one corporal body and urethra, or cleavage of pubic tubercle, wherein each phallus will have two corporal cavernous bodies and urethras. Schneider has classified the condition in three, where we have complete diaphalia or diaphalia of glands alone, and there will be bifid diaphalia. But most widely accepted classification is where we divide the condition in two parts: true diaphalia and bifid diaphalia, bifid phallus. Coming to true diaphalia, we have further two categories under which the complete one, where the separation will be till the shaft of the penis, and in each phallus we have two corpora cavernosa and one corpora spongiosum, whereas in partial the duplicate penis will be smaller or rudimentary, and it is also corresponds to the true partial diaphalia or pseudodiaphalia. Coming to bifid phallus, again we have two categories under it, complete or partial. Then the phallus has only one corpora cavernosa and corpora spongiosum, and separation up to the shaft of the penis. It is called complete bifid diphallus. And when the degree of separation is up to glans only, it is referred to as partial bifid phallus. The associated anomalies will be genitourinary or gastrointestinal musculoskeletal anomalies, for example, uh, duplication of bladder, urethra, and exostrophy of cloaca or bladder, anorectal malformation, like in our case, our patient had imperforate MS, and rectosigmoid duplication, ventral hernia, etc. Coming to the embryology part, it is linked to a defect connecting to the genital tubercle and urethral folds, and seems to occur between 23rd to 25th day of gestation. Also, there is one case which was reported, since in most of the cases karyotype will be normal, but there is this case where the karyotype was karyotype had balanced reciprocal translocation of autosomal chromosome, and which implicated defect in the homeobox genes in the diaphalia formation. Homeobox genes are the master genes for the differentiation. Treatment which is required for these patients, here we stage the treatment. Uh, Principally, it depends on the accompanying congenital abnormalities, as well as preserving the continence and erectile function, which means individualizing each case. Surgical correction is individualized with the aim of achieving proper urinary continence, urinary stream, erection with the adequate cosmesis. And secondly, we treat the diaphalia. Here we can do it by excision of the duplicate non-communicating penis, and penis reconstruction by rejoining the corporal bodies in each penis in a patient with true diaphalia. That is all from my side. Thank you.
Okay, Loveline. Hello.
Hello, yes sir.
Yeah.
I can hear.
This was a case report. So you did the cystoscopy and all in this case, and as you suggested, MCU, RGU, anything like that?
No, we were not able to do, sir, because the patient belonged to very low socioeconomic strata, and further we could not do any treatment in our setup because we didn't have such facilities. So we actually referred the patient to the higher center for further management.
Okay. So you didn't confirm that both the urethras are present in the urethra is present in each penis or not? It was not confirmed.
Yes, we did the catheterization and under ultrasound guided.
Then it was full urethra in both the penises. Okay, thank you.
Darlene, did you see the voiding pattern personally, or
yes,
someone saw the pattern of voiding?
So we actually checked it on our own.
Okay, so one of the penis was dominant, or both were equally voiding?
So both were equally voiding, sir.
Okay.
Okay.
So further investigation must have needed, no? Was this fistula congenital or atherogenic?
Sir, it was congenital because after the treatment, endorectal malformation was treated. The mother told that patient has been passing stool since the birth from the below the second urethra.
What was the age of the patient?
Patient's age was 6 years old when he
6 years.
reported to us.
6 years.
Now, when presented
So
to doctor?
by the time he must have developed some infection, urinary infection or pyelonephritis or some ascending infections.
Yes, sir. The patient presented with history of fever also.
Okay, okay.
Yes, lovely. Now stop your screen sharing. And the next speaker is Dr. Yashodhara.
Thank you very
Lovely.
much. Thank you.
Stop share screening.
Yashodhara.
Yes, Yashodhara, you can now share your screen. She's
Dr.
also
Anwar.
a student from.
Yes, sir.
Dr. Anwar.
Sir, sir.
Dr. Anwar.
Sir,
I have to
am
say
I
that.
audible, sir?
Just see na, the speaker should say a few words for their guides also. They are not
Okay.
giving who was their guide
Okay,
and they are strictly
extremely sorry.
coming with it.
Sir,
Yeah.
sir,
They should say something, few words.
Okay, okay, sir. Take.
Okay.
Yashodhara.
और संजय
Sir.
ठीक है.
Fine, sir.
Yes.
Next speaker.
Dr. Yashodhara.
Good evening, everybody.
Good evening, sir.
Yashodhara, please
Yes, sir.
unmute
Good
yourself.
evening, sir. Yeah.
Sumega.
Yes, sir.
Sumega.
Yes, sir.
All are taking so much time. So please, beforehand, you get connected with them.
Yes, sir.
Where is Dr. Yashodhara?
Yes.
She is,
Now
sir,
start.
she has joined. Screen sharing is there. Bilingual sinus management. Okay. Yes, Dr. Yashodhara.
Thank you, sir. Good evening, sir.
So, Megha, why the? Yes.
Full screen you.
Go ahead.
Slideshow, Yashodhara. Start your slideshow. Yes.
Good evening, everyone. I'm Dr. Yashodhara, second year DNB primary resident from Bokaro General Hospital. I'm going to give you a brief about the two surgical modalities in the management of sacrococcygeal pilonidal sinus. And these are my faculty members, Dr. Shravan Kumar, who is my thesis guide, Dr. Satish Chandra Kumar, my co-guide, and Dr. A.K. Mishra, head of the department. And coming to the introduction, pilonidal sinus is a common benign disease seen in the natal cleft of the sacrococcygeal region, which results in the accumulation of weak and dead hairs, causing inflammation because of foreign body reaction, which or a painful sinus tract in the chronic phase. And it is a chronic disease and undergo on and off acute exacerbations, which is commonly seen in young adult males. There is no definite etiology and pathogenesis, but then the pathogenesis is proved to be described because of the buttock fraction and the shearing forces, and also the suction movement created by the gluteal muscles. The whatever the hairs which are collected in the area, they penetrate and drill through the skin, and so that the pointed ends, they are directed towards the blind end of the sinus, which causes a foreign body reaction resulting in inflammation and then the acute phase, and which then remission undergoes, and then it undergoes into a chronic disease. And is pilonidal sinus disease is also commonly is not just seen in the natal cleft or the intergluteal region, but also can be seen in the commonly occupational disease as a common occupational disease in hairdressers, where you can find the sinus within the interdigital clefts. And also it is known as Jeep disease, as it is commonly seen in the military people. And coming to the inclusion criteria, we'll go on take the patient to the surgery when he is willing to give a written informed consent, and the patient should be an adult. The PT, APTT, and INR level should be within the normal limits. The platelet count should be greater than 50,000 to limit the risk of bleeding, and there should be no active infection at the time of surgery. That is, you shouldn't perform a surgery with in the acute phase of the disease. Coming to the discussion, in case of Limburg's procedure, will perform a rhomboid-shaped excision of the area containing the primary sinus and also the secondary tracts which develop from the primary sinus. Both the upper and the lower ends of the excision being 2 centimeters lateral to the midline, covering the whole area, that is primary and the secondary tracts, will go down deep to the presacral fascia and laterally to the fascia of the gluteal maximus muscle. And then after the excision is performed, the flap is created either from the right or the left gluteal region, and which is slid medially to cover the defect and is sutured. And coming to the Karidakis procedure, we'll give an asymmetrical elliptical incision, the lower and upper ends being approximately 2 centimeters lateral to the natal cleft, so that all the defective tissues are removed until healthy borders are reached, and then the wound edge is mobilized, and then the flap is slit by suturing to the fascia and the skin. And these are the images which are done in our hospital. This is the Limburg's procedure, where the rhomboid excision is performed. This is the presacral fascia, and then flap is prepared and is slid medially and is mobilized, and you can see the tuft of hair with seen in the sinus. And coming to the Karidakis, and these are the images where we'll give us asymmetrical elliptical incision. Excision is performed, healthy borders are achieved until the granulation tissue is seen, and then flap is slid medially and is sutured. And coming to the conclusion, among the two most common surgical modalities of pilonidal sinus, it is said that there is no significant statistical difference between the both, but some say that Limburg's is superior to Karidakis when we consider its low complication rates, the shorter length of the hospital stay, and the high patient satisfaction, and the shorter healing duration. Whereas Karidakis is superior in when we consider its cosmetic results, the chance of flap edema, and hematoma formation. So I'm done. Thank you, sir.
Hi, Dr. Yashoda.
Sir.
My experience is also Limburg's is good, has good results, but Karidakis is good in cosmetic results. Any difference in recurrence of that sinus?
Sir, recurrence is less in case of Limburg's when compared
Why?
to Karidakis.
Any your take on that? Why it is less in Limburg's?
Because of a less chance of hematoma and the post-operative edema.
And if the size of pilonidal sinus is bigger, it has multiple openings.
Then Limburg's is more superior than Karidakis.
Okay, thank you.
Thank you.
Thank you, Dr. Yashoda.
Thank you, ma'am.
Dr. Sanjay, you also want to ask something?
He's offline. Yashoda, kindly say something about your
unmute yourself.
guide.
Sanjay sir, please unmute yourself before speaking. Yes, sir. Now you can say, sir.
I wanted to know which operation commonly is performed at her center. What
Sir,
we are doing
Limburgs is commonly performed.
commonly. That we are doing also the reimburse
Limburgs, I have seen at least
So
15
please,
to 20 cases here.
so please tell me something about your guide also.
We want to listen about your guide.
Sir, actually,
just a small.
Sir, Dr. Shravan Kumar, MS General Surgery is my thesis guide.
Okay.
He cooperates me and also promotes me in more about he always puts me in first when he posts a case.
Okay.
Yeah, nice.
Okay, Dr. Yashodhara, just stop your screen share.
Okay.
Now, Dr. Piyush, you can start. He is JR in RIMS. Piyush, you can start your screen sharing.
सुमेघा अगले वाले स्पीकर को फोन करके रेडी रखो.
हाँ नहीं सर
Then
रेडी
you
है
will save time.
वो थोड़ा सा तो टाइम लगता है. हाँ.
Okay, Dr. Piyush.
Full screen करो पीयूष. Do it full screen.
Just click on your main screen, it will enlarge.
पीयूष full screen करो. Slideshow.
Piyush, can't you?
You are not audible,
Yes.
Piyush.
Unmute yourself. Piyush, you are not audible. Unmute yourself. Unmute yourself. Piyush, unmute yourself.
Piyush, you are not audible. Please stop and unmute yourself.
Start from your first slide.
Yes, ma'am.
You can start now. Okay.
And myself, Dr. Piyush Tarve, JRA2 from RIMS Ranchi. My guide is Professor Dr. Sheetal Malwa and co-guide is Dr. Janit Hers Kirketa, Assistant Professor. My topic is Meckel's diverticulum perforation, a rare yet a common finding. Introduction. Meckel's diverticulum is a congenital diverticula found in about 2% of population. It is a persistent vitellointestinal duct. It arises at antemesenteric border about 60 cm from IC junction. Although rare, it is a common intra finding presenting usually when complicated. Here is a case of perforated Meckel's diverticula presenting as intestinal perforation. Rate of perforation of Meckel diverticula is only just 0.5%, hence making it a rare case report. A 24-year gentleman presented at emergency room with a 3-day-old history of severe pain at lower abdomen, sudden in onset, which was localized in periumbilical area and had shifted to the right iliac fossa. No history of fever, vomiting, diarrhea or bleeding per rectum. On examination, patient was dehydrated, abdomen mildly distended, localized guarding and rigidity at right iliac fossa and periumbilical region. Bowel sound was exaggerated. Liver dullness was obliterated. Per rectum examination was normal. DRE was within normal limits. After full workup, routine examination, there was leukocytosis 18,000 and raised creatinine and hypokalemia. X-ray chest shows gas under right dome of diaphragm and X-ray abdomen erect, normal except gas under diaphragm. Diagnostic tap was done and aspirated intestinal content with food particle. Management. Surgery, explanatory laparotomy was done after resuscitation. Intra-op, a diverticula was found about 2 feet proximal to IC junction, which was inflamed up to the base and was perforated at the tip. Resection and anastomosis was done and resected diverticula was sent for biopsy. HPE showed inflamed intestinal segment with no evidence of any heterophic, gastric or pancreatic tissue. Post-op recovery was uneventful and patient was discharged on POD 9. The first figure shows that X-ray where the gas under diaphragm we can see, and the second one, the second figure, there is a perforation at the tip, and third one the base was inflamed, and the fourth one is also showing that base was narrow and it is inflamed. Discussion. Meckel's diverticula is a persistent vitello-intestinal duct firstly described by John and Frederick Meckel. It usually closes at 7 to 8 weeks. It is found in about 2% of population at antimesenteric border about 2 feet from proximal to IC junction, having all three coats and its in only 2% of population, it is symptomatic, thus is an incidental finding most of the time. In suspected cases, in childhood, technetium-99 per technet scan, Meckel scan is done to diagnose it with 95% specificity, but in adult, it is only specific. In symptomatic, if symptomatic, it is due to complication, that is either hemorrhage, that is most common, 30%, inflammation, ulceration, perforation, that is 0.5%, or interception, intestinal obstruction, 20%, herniation, that is Litter's hernia, and heteropic gastric or pancreatic tissue up to 20%. Very rarely, in about 0.2%, neoplastic changes can occur. The overall lifetime complication rate is 4%. Most of the time, laparotomy is done for appendicitis or appendicular.
I think something went wrong.
Yeah, it is not audible.
He's not audible. I think his connection got lost.
Perhaps.
We can wait, or sir, should I?
We can move to for next.
Sir, or should I call the next speaker?
Next participant.
Okay, so Narayan, unmute yourself and start your.
Yes, ma'am.
Screen sharing. Yes. Start your screen sharing, Narayan.
Okay, ma'am.
Okay.
I suggest all the speakers please open your PowerPoint on your laptop so that once you start sharing, it is directly the presentation that can be shared. What is the issue, Sumekha? Sumekha?
Yes, ma'am.
Narayan.
Yes.
Yes.
Share your slides.
Yes.
Narayan, you can start. कोई बात नहीं. Piyush will finish later on. ठीक है? उसका कुछ नेट में प्रॉब्लम आ गया था. Narayan, just open your PPT.
Okay, so you just ask the next person. You just ask the next person to open the PowerPoint and be ready on his laptop, so that once this is over, the other person can start sharing.
Mukesh is our next speaker.
ये मैं कैसे share screen से ये अच्छा ये है.
Who will be continue now? Who will continue now?
Yes.
Narayan or Mukesh?
Yes, ma'am. I'm ready, ma'am.
Okay, Narayan. Now full screen करो.
Yes.
इसको.
Good evening, everyone.
Just do the full screen, na?
Yes, sir.
Okay.
Full screen karo.
Okay, go ahead.
Yes, sir. Good evening, sir. I'm Dr. Narayan, JR2, Department of Surgery, RIMS Ranchi. My guide is Dr. Krishna Murari, sir. And my topic of discussion will be adult choledochal cyst. Choledochal cyst is an aneurysmal dilatation of the bile duct. It is a rare condition with incidence between 1:1 lakh and 1:1.5 lakh live birth in the developed country, although it is probably more common in the developing countries. Cysts of bile duct are more common congenital lesions than is biliary atresia. Case report: a 30-year-old previously healthy female patient was admitted through outpatient clinic with a history of right upper quadrant abdominal pain, which was colicky in nature, moderate in severity, recurrent for the last 9 months. There was no aggravating or relieving factors. The patient denied any history of jaundice or fever associated with abdominal pain. The patient was well nourished and not jaundiced.
What is happening today? Piyush, are you there? Piyush, are you there? Can you continue where you left? So our next speaker. Narayan, what happened? Narayan, unmute yourself
Unmute.
first.
Loss of connection, ma'am.
Okay.
Now I think that, ma'am, am I audible?
Yeah.
Yes.
You are audible. Please continue.
Share your slides also, na?
Oh, sir. Yes. Yeah. Abdominal ultrasound showed a few. Yeah. Am I audible, sir?
Yes. Perfectly.
Abdominal ultrasound showed a fusiform dilatation of the common bile duct measuring around about 6 into 3 centimeter with small stones in the choledochal cyst. No intrahepatic biliary dilatation. Liver was also normal. Pancreas was also normal. There was thick gallbladder with multiple stones. Abdominal CT study confirmed the presence of an oval-shaped cystic dilatation of the CBD measuring 6 into 3.5 centimeter, representing choledochal cyst. There was biliary. We can see the CT scan is here. We can see a dilatation, oval-shaped dilatation, and in MRCP we can see a oval-shaped or fusiform common bile duct.
Okay.
At laparotomy, oval-shaped cystic dilatation of the CBD was there. The cystic duct was entering the upper end of the choledochal cyst. The gallbladder was removed. Excision of the cyst was performed, and Roux and Y hepatico-jejunostomy was performed. About 25 centimeter distal to the duodenojejunal flexure, joined to the common hepatic duct above the cyst. No liver biopsy was performed. She was kept in the hospital for 5 days and discharged home. The pathology confirmed choledochal cyst without any malignancy. The patient was followed up after 6 weeks and there was no complication. Choledochal cyst is due to specific weakness in the part or whole of the CBD. This consists of congenital cystic dilatation of the extrahepatic biliary tree, intrahepatic biliary radicle, or both. A cyst may also develop after trauma or fibrosis or stenosis of the distal CBD from the recurrent cholangitis associated with stone in the bile duct. Early changes of this type are sometimes seen at ERCP. It is more common in female than males, and the ratio is 4:1. The classical triad of pain, jaundice, and abdominal mass occurs only in 6% of cases. In our case, although we found multiple stones in the choledochal cyst, we think that these stones are secondary and not because of choledochal cyst. Because there was no previous attack of jaundice or cholangitis, also with no history of previous trauma or surgery on the CBD, the cause of choledochal cyst most probably is the anomalous pancreatic bile duct junction. Several types of choledochal cyst are described. Type 1 is diffuse choledochal cystic dilatation. Type 2 is diverticulum of the common bile duct. Type 3 is diverticulum within the pancreas. Type 4 is extension into the both intrahepatic or extrahepatic duct. Type 5 is cystic dilatation only in the intrahepatic duct. Type 5 is a hereditary disorder that is autosomal recessive and is also known as Caroli's disease and carries a poor prognosis. So coming to the conclusion, the prognosis for most patients with cyst of extrahepatic bile duct appropriately resected and reconstructed is excellent. Thank you, sir. This was my presentation.
Okay, Narayan. It was posted in your routine OT or emergency OT?
Sir, it was in my routine OT, sir.
Routine OT. So all the workup has been done. Is there any scope of minimal access in this case?
Hello.
ERCP?
Sorry, sir, I can't hear you, sir.
I am asking, is there any minimal access surgery for this patient? Is this particular patient for fusiform dilatation? Like ERCP?
Yes, sir. By ERCP, sir, it can be done, sir.
It can be complete treatment, or it's just a timeline system?
Just, sir, a timeline management if there is more obstruction, because it is a precancerous condition, sir. So basically, we have to remove the cyst because it can lead to cholangiocarcinoma. So, sir, I think that the best is the excision followed by Roux-en-Y hepaticojejunostomy.
Okay, thank you, thank you.
Thank you, sir.
Okay, Narayan, now you can stop your screen sharing.
Okay, ma'am. Thank you, ma'am. Thank you, sir.
Stop your screen sharing.
Stop share, yes, sir.
So, Piyush, can you complete your presentation from where you left? Piyush? No, he's not responding. So I call our next speaker, that is Dr. Mukesh. Oh, so Piyush is sharing his screen. Okay.
Okay.
Yes, Piyush, continue. You are not audible, Piyush.
Yes, ma'am.
Yes.
Go ahead. Go ahead.
Go ahead.
Ma'am, myself, Dr. Piyush Tarve, JRA2, RIMS Ranchi. My topic of discussion is Meckel's diverticulum perforation, a rare yet a common finding. My guide is Professor Dr. Sheetal Malwa, and my co-guide is Dr. Jenith Hers Kirketa, Assistant Professor. Introduction. Meckel's diverticulum is a congenital diverticula found in about 2% of population. It is persistent vitellointestinal duct arising at antimesenteric border about 60 cm from IC junction. Although rare, it is a common intra finding presenting usually when complicated. Here is a case of perforated Meckel's diverticula presenting as intestinal perforation. Rate of perforation of Meckel diverticula is only 0.5%, hence making it a rare case report. A 24-year gentleman presented at emergency room with 3-day-old history of severe pain at lower abdomen, sudden in onset, which was localized in right iliac fossa and periumbilical region. No history of vomiting and diarrhea or bleeding per rectum. On examination, patient was dehydrated. Abdomen was mildly distended with localized guarding at right iliac fossa and periumbilical region. Bowel sound was increased. Liver dullness was obliterated. On per rectum examination was normal. DRE was within normal limit. We have routine blood investigation. There was leukocytosis around 18,000 and raised creatine was raised 1.7 and hypokalemia was there. On X-ray chest, PA, there was gas under diaphragm, right dome of diaphragm was seen. and X-ray abdomen erect, they're normal except gas seen under the diaphragm. Diagnostic tap was done and aspirated intestinal content with food particle was found. Management. So, we have done exploratory laparotomy was done after resuscitation. Intra-op a diverticula was found about 2 feet proximal to IC junction, which was inflamed up to the base and was perforated at the tip. Resection and anastomosis was done and diverticula was sent for biopsy. HPE shows inflamed intestinal segment with no evidence of heterophic gastric or pancreatic tissue. Post-op recovery of the patient was uneventful and he was discharged on POD 9. The first figure, this shows X-ray shows there is gas under right dome of diaphragm. The second one is showing the Meckel's diverticulum perforation, and the third one is also showing there was a narrow base, and the fourth, the tip was also perforated. Discussion. Meckel diverticula is a persistent vitellointestinal duct firstly described by John Frederick Meckel. It usually closes at 7 to... Ma'am, I am audible?
Yeah.
Yes.
You are audible.
It usually closes at 7 to 8 feet. It is found in 2% of the population at anti-mesenteric border at about 2 feet proximal to IC junction, having all three coats and its own blood supply. In only 2% population, it is symptomatic and thus an incidental finding most of the time. In suspected cases in childhood, technetium-99 per technet scan, that is Meckel scan, is done to diagnose it with 95% specificity. But in adult it is only specific. If symptomatic, it is due to the complications. Most commonly the hemorrhage, inflammation, ulceration, perforation, intussusception, intestinal obstruction, herniation, and heteropic gastric or pancreatic tissue. Very rarely, about 0.2% neoplastic changes can occur. The overall lifetime complication rate is 4%. Most of the time, laparotomy is done for appendicitis or any intestinal or appendicular perforation. A Meckel diverticula is found. If found, it can be left as it is if the base is not inflamed, but should be resected if the base is involved or any complication is there. If a band is present, it should be divided and diverticula should be resected followed by anastomosis. Meckel diverticula, although rare, but can be found very frequently in the community. If patient comes with features of intestinal perforation, Meckel diverticula can be thought at least for once by the surgeon. Also, if a patient complains of chronic pain in lower abdomen or obscure bleeding per rectum, Meckel diverticula can be a culprit. Thus, a thorough knowledge of the diverticula is necessary in making diagnosis and to decide when to operate or when to not. Thank you.
Okay, Piyush. In your case, resection and anastomosis was done. Any other surgical modality in other cases?
Sir,
like diverticulectomy can also be done in some cases or not?
So once again,
screen sharing, Piyush. And
I am asking, in your case, resection and anastomosis was done. Okay.
Yes, sir.
In some cases or few cases, diverticulectomy can also be done. So when it can be done? In each case, you will go for resection and anastomosis?
Sir, in Meckel's diverticulum, wedge resection is done. It is the treatment of choice.
Yeah. When it can be done? In your case, you people.
So when the base is narrow, or it is perforated.
In a simple cases without much more complications, if it mimics acute appendicitis, and if someone goes for acute appendicectomy and you get diverticulum, then wedge dissection can be done. Okay, thank you, Piyush.
Okay, Piyush, stop your screen sharing.
Thank you, ma'am.
And now Mukesh, you can start your screen sharing. Dr. Mukesh, unmute yourself. Mukesh, first unmute yourself. And start your screen share, Mukesh. start. Open your PPT, Mukesh.
Yeah.
Full screen. Okay, now start. You can start now. Mukesh, you are not audible.
Yeah.
Mukesh, unmute yourself. Mukesh, first unmute yourself. Mukesh, first unmute yourself, then speak. Mukesh, unmute yourself, then speak. Unmute yourself. Mukesh, you are not audible. Unmute yourself and then speak, please. Mukesh, please unmute yourself. Mukesh, unmute yourself first and then speak. You are not audible.
Mukesh, go back to your Zoom where you logged in. So there you have to unmute yourself, then start speaking. Click on that Google Chrome icon.
Just tap.
Go back to Google Chrome. Go back to Google Chrome. Yeah, unmute.
Yeah.
Unmute yourself. Click on unmute. Unmute. Yeah. Now go back to your slide. Slide sharing. Yeah. Minimize it. Minimize it. You're already. Go back to your slide share.
Open your PPT and then start your presentation and share your screen. Okay, now start your presentation, Mukesh. You can speak now. Mukesh, you're audible now. You can speak. You can start your presentation.
You are not audible, Mukesh.
So he is not speaking actually.
Okay.
He has unmuted himself, but he is not speaking right now. Now, Mukesh, start your presentation. Say. You're not audible till now.
Speak, Mukesh. Your slides are visible to us. Just speak. Start your.
You can see his slides only if he is unable to have audio.
वीडियो ऑफ कीजिए 5 सेकंड के लिए, फिर ऑन कर लीजिए, खत्म। सब लोग यही करता है। राइट हैंड से आप कैमरा पे आ रहे हैं, वो नहीं, बस क्लिक कीजिए ना तो आ जाएगा। बस क्लिक कीजिए कहीं भी। हाँ, म्यूट कीजिए।
Okay, now Mukesh is having some problem in sharing his screen. Now Rajat, are you ready? Rajat, are you ready?
Yeah, ma'am.
With your PPT?
Yeah, ma'am.
You can start now, Rajat. Very good. Now you can start your screen share and start your PPT presentation. Okay.
Okay, ma'am.
So our next presenter is Dr. Rajat Kumar Singh. He is a JR2 in RIMS. His topic is myeloma, a rare complication of cholecystectomy. Now Rajat, you can just share your screen, open your PPT and share your screen.
Okay, ma'am. Yeah, ma'am. I am audible.
Yeah, you are audible. Go ahead. Can you make your hand?
Ma'am, good evening to all. Ma'am, myself Rajat Kumar Singh, junior resident, second year, Department of General Surgery, RIMS, Ranchi. My topic is myeloma, a rare complication of cholecystectomy. Introduction. Myeloma is an encapsulated collection of bile outside or inside the biliary system within the abdominal cavity. It is a rare complication with an incidence of 0.322%. Cause of myeloma include traumatic biliary system injury, spontaneous rupture of biliary tract, and abdominal injury. The bile collection usually occur after biliary surgery, and the most common site is subhepatic space. More than 50% of myeloma originate from cystic duct. The presentation varies from abdominal pain, jaundice, and fever to even peritonitis. An abdominal ultrasound is the first imaging modality to diagnose myeloma, but it is equivocal to the CT scan. Case report. A 44-year-old female presented to our hospital emergency with an complaint of fever, nausea, vomiting, and pain in right upper quadrant. Elective laparoscopic cholecystectomy was done 4 weeks before the recent visit. On clinical examination, he was in acute distress. His pulse was 120 per minute. He was febrile and her respiratory rate was 25 per minute. On abdominal examination, she had mild epigastric tenderness without any sign of peritoneal irritation and Murphy's sign was negative. Workup. Her initial blood work revealed a WBC count of 24,000, hemoglobin level of 12.9 gram. LFT was elevated. Actually, LT is 155 and AST is 120, and bilirubin level was normal. Ultrasound of abdomen show a well circumcised, non-homogeneous fluid collection in right lobe of liver. CT scan of abdomen was done to confirm the lesion and it saw 5.2 into 5.4 into 4.6 centimeter, reminiscing subhepatic fluid collection. Management. Percutaneous drainage was performed with 12 French pigtail catheter and 700 ml of bile was drained. Here the slides of CT scan are there. They are with blue arrow. I indicate the collection, subhepatic collection. and through red arrow, I indicate the collection in seen in the ESG. Discussion. The clinical presentation of biloma is variable and it could present with diffuse or localized abdominal pain, fever, and jaundice. Elevated liver enzyme and leukocytosis may also be seen. Clinical presentation of biloma are variable and non-specific, and the diagnosis is based on clinical and radiological, uh, like ultrasound or CT scan finding. Sometimes fluid aspiration analysis is required to confirm the diagnosis. Discussion. If biloma is small, no treatment is required and only observation is enough. Most post-operative biloma are managed by percutaneous drainage. Uh, Biloma can be infected and cause serious and life-threatening complications such as peritonitis, biliary fistula, which can lead to empyema, bulimia, and hemophilia. In conclusion, biloma is a rare medical condition. Early diagnosis through imaging technique and prompt treatment can prevent life-threatening complications. ESG guided percutaneous drainage is an affordable treatment option for biloma with excellent results.
दिख रहा है ना, ये हो गया.
Okay, Rajat, you have completed.
Yes, sir.
Your case was a post-open cholecystectomy or post-lap cholecystectomy?
Lap cholecystomy, sir.
Okay. If it is not resolved by simple prectal catheter drainage, then what can be done? Because there is continuous discharge, you are getting it daily in your daily rounds. Biliary drain bile is present. What you will do then?
So then, when we have to open it, it is most likely be the bile duct injury. So we have to do cystoenteric anastomosis for that.
Without any workup? How you can decide the level of injury or the gravity of the injury is how much?
Because, sir, after 4 to 5 days of pigtail catheterization, nothing is come after that.
Nothing should come.
Collection.
But if it is coming, then biliary injury is there. Then
yes,
MRCP should be done.
Yes, sir. MRCP is done to know about the common bile duct injury, where the leakage is, what the size is. Actually, all about the injury through MRI or MRCP, we know about that.
Okay. And ERCP?
ERCP, sir, ERCP, because it is beneficial if proximal. Yes, sir. It is beneficial only for proximal CVD, sir.
Yeah, that's what I wanted to do. Yeah, go ahead.
If it is digital, for digital CVD injury, sir, we do nothing by ERCP, sir.
Okay. Thank you.
Okay, thank you, Rajat. And now you can stop your screen share. Rajat, just stop your screen share. Yes. And now our next speaker is Dr. Ajju Kumar. He is also JR entrance. His topic is transmesocolic hernia with jejunal obstruction, a rare presentation of an acute abdomen. So, Dr. Ajju, go ahead, start your screen share.
इधर आइए मेरे लैपटॉप पे.
डॉक्टर अज्जू यू कैन स्टार्ट.
माइक नहीं चल रहा है. आप बेचारे बोलते जा रहे हैं. मेरे को आवाज इधर सुनाई दे रही है, इधर से नहीं सुनाई दे रही है. अब माइक खराब है तो हम बताइए क्या करें. बस हम बोल रहे थे लैपटॉप में गड़बड़ी है. तो ये सब कुछ सेट कर दिया. उसके बाद
अज्जू जस्ट अनम्यूट योरसेल्फ. अज्जू अनम्यूट योरसेल्फ.
हेलो. हाँ,
just unmute yourself, Ajju.
अरे क्लिक बस कीजिए, क्लिक कीजिए.
Aju, are you there?
Yes, ma'am.
Start saying. I am sharing your slides. Okay. बोलना शुरू करो. I am sharing your slides.
Good evening, everyone. I am Aju Kumar, second year junior resident from RIMS Ranchi. Today I am presenting a case report. Topic is transmesocholic hernia with jejunal obstruction, a rare presentation of an acute abdomen. Internal hernia is, by definition, protrusion of a viscous or a part of viscous through anatomical or pathological opening within the limits of peritoneal cavity. According to literature, several main types are described by Mayers based on the location. All incidence is low, it is less than 1%. It accounts for 0.5 to 5% of all the cases of intestinal obstruction. Transmesocholic hernia is extremely rare type because it is almost 5 to 10% of all the internal hernia. My case report is a 40-year-old gentleman with history of abdominal distension, not passing a stool and flatus, and vomiting for 3 days. And vomiting was bilious, and there is no past history of any gastrointestinal surgery. On examination, tachycardia was there, generalized abdominal distension was there, and tenderness and rigidity, especially in the upper half of the abdomen. External hernial orifices were normal, bowel sounds sluggish. On digital rectal examination, rectum was empty. This is the X-ray of that patient. Multiple dilated small bowel lobes are visible in the X-ray, and the features on X-ray suggest the jejunal lobes most probably. In pre-op, patient was diagnosed with acute abdomen with acute intestinal obstruction. The diagnosis was confirmed intraoperatively. On surgical exploration, lobes of jejunum herniated through a small defect of 5 into 6 centimeter in transverse major column. Jejunal lobes contained in thick hernial sac, which was extending into the supracolli compartment. Herniated lobes were reduced and transverse major colon defect was repaired. As herniated lobes were clearly viable, nothing was done with that. Post-operative period was uneventful. On the POD 11, patient was discharged. And during the follow-up, we have done the barium studies, and a small intestine was normal after that. This is the picture taken in intra-op hernial sac through the defect in the transverse major colon. Yes, ma'am. Next slide. This is the during intra-op after releasing the content of the hernia sac. Discussion: the clinical signs and symptom of lesser sac hernia.
Anju, go ahead.
Aju, go ahead. Aju, go ahead. Can't you see the screen? Aju, you're not audible at all.
Unmute yourself. Sumit, can you see whether Aju is unmuted or not? Sumit, you are the co-host. So Megha, are you the co-host?
Ma'am, I'm the host and I'm reading my screen. Okay, now
So
Aju,
just ask him to unmute himself. Send him a request to unmute.
Okay.
He is
Aju,
not in
I
the
think his
participant list.
connection is lost.
He is not in the participant
He has
list.
left.
He has left.
He has left.
He is not in the participant list.
There's something wrong with this connectivity.
Can
Dr.
go
Vivek
with
is
the
also
next
there.
participant.
Dr. Kshitij. So our next speaker is Dr. Kshitij. Just unmute yourself and start your presentation. Open your PPT and start screen sharing. Dr. Kshitij, yes. You have unmuted, very good. And now start your screen share and open your PPT and start your screen share, okay? Anwar sir, please unmute yourself to say something.
Yeah. Oh, he's Aju. The discussion was not over. Aju,
No, this
you
is
want
Kumar
to go?
Kshitij.
Actually, sir,
Now
there
this
will
is
be
Kumar
some
Kshitij.
connectivity issue. Aju left while his presentation. So we will join him again. And now we are starting with Dr. Kshitij. He will be presenting now. And later we can join contact Aju.
Can I start?
Yes, Dr. Kshitij, you start your presentation.
Okay. Good evening, everyone. I'm here. My name is Dr. Kumar Shitij. I'm DNB first year resident at. I'm here to present a poster on intestinal lipoma and unusual presentation. I've been guided by Dr. Nima Verma. Intestinal lipoma is a benign, slow-growing mesenchymal neoplasm arising from adipose connective tissue in the bowel wall. Lipomas can be found throughout the gastrointestinal tract, although they are more frequently seen in the colon. Approximately 90% of colonic lipomas are submucosal. The remainder of these tumors are subserosal or intramucosal in origin. Although lipomas generally remain asymptomatic, when they exceed 2 cm in diameter, they may cause abdominal pain, obstruction, or intussusception, and also can cause radiological and endoscopic confusion with malignancy. The clinical manifestation depends upon tumor size, localization, and complications. We report a young woman with submucous lipoma in the terminal ileum who presented with acute abdominal pain with signs of intestinal obstruction. Presented with a 2-day history of colicky abdominal pain, bilious vomiting, and not being able to pass stool or flatus. The patient did not have any comorbidities and she did not have any surgeries in the past. On examination, she was apyrexial and hemodynamically stable. Her abdomen was mildly distended with generalized tenderness and no palpable abdominal masses. Bowel sounds were hyperaudible. Initial laboratory investigations were normal. Plain abdominal X-ray showed dilated small bowel loops with no evidence of free intraperitoneal air on chest X-ray. CCT abdomen suggested small bowel obstruction with cutoff in distal ileum. Here's the X-ray film of a plain abdominal X-ray, which shows small dilated bowel loops. Here's the CCT abdomen coronal section showing small bowel obstruction with cutoff in distal ileum. And here's the CCT abdomen transverse section of the same. The decision was made to undertake an urgent exploratory laparotomy. At laparotomy, through midline incision, ileo-ileal intussusception was found with a small growth of about 2 into 2 cm, 25 cm proximal to ileocecal junction. Resection and anastomosis of ileum was done using stapler. Antibiotic coverage was given post-operatively. Patient was kept NPO till 3rd post-operative day, after which lipids were allowed. On 5th post-operative day, soft diet was allowed. The patient did well and was discharged on 6th post-operative day. On histopathological examination, it was found to be a lipoma of small intestine, submucosal lipoma of the small intestine, in which peripheral part was ulcerated, necrotic, hemorrhagic with acute inflammation. Here's the histopathological slide of the same. This is a site of ileal lipoma shown during surgery. And these are the specimen of the resected segment immediately post-op and after a month, which shows the cut section. Lipomas are benign tumors of mesenchymal origin. They are the second most common benign tumors in small intestine and account for 10% of all benign gastrointestinal tumors and 5% of all gastrointestinal tumors. Gastrointestinal lipomas are most commonly located in the colon, which accounts for 65 to 75%, especially on the right side, followed by small bowel, which accounts for 20 to 25%, and occasionally in the foregut, which accounts for less than 5%. Tumors of the small bowel are rare. Their incidence ranges from 0.6 to 2% among all gastrointestinal tract tumors. The incidence of lipomas among all benign small bowel tumors is reported to be 21.4%. Smaller lesions do not cause many symptoms. However, larger lesions invariably lead to intussusception and presents at acute obstruction. For symptomatic lipomas, surgical resection has traditionally been required. I would like to conclude that small bowel lipomas can cause intussusception presenting as obstruction. CCT abdomen is important adjunct in preoperative diagnosis. A high level of clinical suspicion and an abdominal CT scan are most useful tools for making a timely diagnosis. Surgical excision remains the treatment of choice and produces an excellent prognosis. The authors will like to thank everyone who were involved in this case, which includes Dr. Prasanna Dora, Dr. Chandan Kumar, Dr. Vikas, Dr. Soma Datta, Dr. Bhupendra, Sister Mary, and Sister Gemma. And that's all. Thank you.
Kshitij, it was a really nice presentation. Okay,
you,
sir, go ahead. Sanjay sir, go ahead.
Okay. It was nice presentation. I want to know whether there was any symptom prior to obstruction or not.
No, sir. No, sir. She presented as acute bowel obstruction. There were no symptoms. She remained asymptomatic before that.
Okay, you had no choice than doing this laparotomy.
Yes, sir.
Okay.
Kshitij, your guide is.
We can't hear you.
Kshitij?
Yes, sir.
Who is your guide?
Dr. Arunima Verma.
Yeah, that's why your slides are such in a nice way. You presented your slides. Thank you. It was a nice presentation.
Yes,
Thank you, Dr. Kshitij. And now, Dr. Aju, from where you left, can you continue?
Oh, he has joined now, Hannah. Yeah.
Dr. Aju has joined, so he will continue. Dr. Aju, are you there?
Aju, please speak.
I think he left from discussion part. Yes, Aju, please speak.
He has joined. Yeah.
Is Achu unmuted? Because we can't see him in the list.
Aju, unmute yourself. Aju, unmute yourself. Aju, please unmute yourself.
So Megha, you can send him a request to unmute himself. You are the host.
Already sent, ma'am.
So give him a call.
Madam, we are sending him request, but he is not accepting it.
So go ahead with the next presentation.
Okay. Now I'm calling next speaker, Dr. Mukesh. Dr. Mukesh? Yes. Yes, Dr. Mukesh, good evening. Now open your PPT and start your screen share. Dr. Mukesh Kumar Singh is here in RIMS, and he will be presenting a case of clear cell carcinoma, rare malignancy. Yes. Yes, Dr. Mukesh, go on.
Yes, ma'am.
Full screen.
Myself, Dr. Mukesh Kumar. Yes, ma'am. Myself, Dr. Mukesh Kumar Singh, JR2, RIMS Ranchi, Department of Surgery. Coming to introduction, ma'am. Clear cell sarcoma of tendon and aponeurosis or soft tissue or simply just clear cell sarcoma are tumor of very low incidence derived from neural crest cell originating from the soft tissue representing an estimated 1% of all sarcoma. Yet the true incidence remains unknown. Clear cell sarcoma was previously characterized as malignant melanoma of the soft tissue, but contemporary techniques have made this designation obsolete. Incidence is on average during the third decade. The male-female ratio is approximately 1:1, although clear cell sarcoma seems to be slightly more common in female. The lower limb are most frequently affected. The most common presentation is slowly growing and tender or painful lump of the extremity. As the tumor grows, it invades nearby tissue and over time, symptoms of more advanced cancer might develop including weight loss, malaise, and loss of appetite. The 5-year survival is estimated to 63% and tumor size is implicated in the prognosis. Case report. A 28-year male presented to surgery OPD with complaints of gradually increasing lump over back of left thigh for 1 year. Pain associated with bloody discharge over lump since last 5 to 6 months. On examination, a pedunculated mass of size 8 into 6 into 4 centimeter present on back of left thigh, which bleed on touch. Workup. Routine examination and investigation where normal USG was done, which shows a large well-defined heteroechoic soft tissue mass lesion with high internal vascularity in posterior left thigh region. Management. Wide local excision was planned for the case in routine OT. The excised mass was sent for HPE after the procedure. This is the lump, ma'am, over the left thigh, and this is the specimen which is sent for pathological examination. This is the slide of pathological examination. Now coming to discussion. In this case, a 28-year-old man presented with localized pain and expanding mass and lethargy. In previous cases of clear cell sarcoma manifestation resembling the current case, we are evident mean age and localization of tumor are parallel to the present case, as the lower limb seems to be the most frequently affected. In a retrospective study of patients with clear cell sarcoma, the tumor occurred predominantly in young patients between the age of 15 and 35 years. The treatment protocol of both clear cell sarcoma and malignant melanoma was followed in the current case, as malignant melanoma of this size should be surgically removed with a margin of 2 cm. Discussion. Follow-up differs as chemotherapy may be beneficial in selected case of malignant melanoma, whereas clear cell sarcoma does not seem to respond to neither chemotherapy nor radiation. Approximately 2/3 of all clear cell sarcoma contain melanin and therefore are S100 positive, whereas the immunological profile for clear cell sarcoma is typically positive for melanin A, HMB45, and microphthalmia transcription factor. In 90% of all cases of clear cell sarcoma, polymerase chain reaction and fluorescence in situ hybridization can detach the translocation from chromosome 12 to chromosome 22 from long chromosome of 12 13 position to long arm of chromosome 12 of 13 position to long arm of chromosome 22 of 12 position, or a resultant EWSR1 ATF1 fusion gene unique for clear cell sarcoma. Now coming to conclusion, although clear cell sarcoma is a rare tumor, it should be kept in mind in cases of patients presenting with tumor of the soft tissue. Furthermore, an initial diagnosis of malignant melanoma in tumor of the soft tissue should warrant further examination to exclude clear cell sarcoma. For the optimal specific treatment, albeit all delays should be diminished if possible, as more time is spent on diagnosis potentially equal a larger tumor and more sinister prognosis. Thank you.
Yes, Mukesh.
Yes, yes, sir.
As it was a wide excision, so defect was repaired by
Skin grafting, sir.
in the same sitting or in a different sitting?
In the same sitting.
Okay, thank you. Follow-up has been done for how many time? Because you are a JR, so within 6 months or 1 year, it has been followed up by you for this patient.
The first follow-up in 6 weeks and second follow-up after three months.
3 months. So you have followed the 3 months also, Abhi?
Yes, sir.
Okay, the patient is perfectly all right?
Perfectly, sir.
Chances of recurrence?
The chances is margin is margin not free from tumor, then recurrence chances.
So histopathology report suggested the margin is free?
Yes, sir.
Okay, thank you, Mukesh.
Thank you.
Okay, Mukesh, now you can stop your screen share.
Yes, sir.
Sanjay sir, you want to ask anything? Sir, first unmute yourself. Sanjay sir, you are not audible. Unmute yourself. Yes. Sir, unmute yourself. Yes, sir. Now you are unmuted.
No, I only wanted to ask whether he had taken biopsy from the sides of the margin or not, and had taken biopsy in follow-up cases period or not. Okay, I think his.
Yes, Mukesh, you can answer. You should answer. No. You can answer, Mukesh. Yes.
Yes, ma'am.
Answer what Sanjay sir is asking.
Oh,
what is the question, sir?
Did you take biopsy from the edges or not? Or
no, sir. No, sir. Direct wide local excision, sir.
Okay. Okay. Thank you.
Okay. Thank you,
Okay,
sir.
thank you, Dr. Mukesh. And now our next speaker is Dr. Amit Minch. Amit? Yes, you are there.
Yes, ma'am.
Also here in RIMS, and his topic is a rare case report on Meckel's diverticulum perforation. Now, Amit, you can start your screen share and continue.
Yes,
Amit, start your screen share.
yes, ma'am.
Yes, and continue. Amit, open your PPT.
Yes, ma'am. I have already opened, ma'am.
So you need to share your screen.
Yes, ma'am. I am sharing.
Yes, go ahead. Amit, go ahead.
Myself, Dr. Amit Green, junior resident, second year, Department of General Surgery, RIMS Ranchi. My poster presentation is on topic a case report on Megal's diverticulum perforation. Introduction. Megal's diverticulum is the result of the incomplete obliteration of the vitelline duct. It is often referred to by the rule of two. In 2% of the population within 2 feet of ileocecal valve, 2 inch in length, 2 types of heterotrophic mucosa, and presentation before the age of 2. Meckel's diverticulum is the most common congenital abnormality of the gastrointestinal tract. However, it rarely presents symptomatically. Perforation is an uncommon presentation, particularly among older age groups. Perforated Meckel's diverticulum often presents as does perforated acute appendicitis. This resemblance often results in diagnostic inaccuracy. Despite uncommon incidence of symptomatic Meckel's diverticulum in adults, the morbidity associated with it is significant. Case report. A 46-year-old male who presented with pain abdomen since 5 days, a history of worsening abdominal pain associated with fever and vomiting. On his admission, patient was toxic, but his vitals were within normal range. On physical examination, abdomen was distended with guarding, rigidity, and generalized tenderness. On chest X-ray PAU, bilaterally gas and diaphragm was found. Workup. His blood analysis report revealed slight elevated blood counts. His TLC was around 13,200. Hemoglobin was 10.7. RFT is within normal limit, and the patient was in hypokalemia. Management. During the operation, an examination of the small bowel revealed an inflamed and perforated Meckel's diverticulum at approximately 75 cm proximal to ileocecal valve. Dissection and anastomosis of the ileal segment was performed. This is the picture showing Meckel's diverticulum, and this is the perforated part of the diverticulum. Discussion. Symptomatic Meckel's diverticulum is more commonly seen in children within a mean age of presentation at around age 10. Among adults, symptomatic Meckel's diverticulum is even rarer. The estimated lifetime risk for developing complications of Meckel's diverticulum range from 4 to 6.4%. Complications of Meckel's diverticulum include hemorrhage, bowel obstruction, inflammation, perforation, intussusception, volvulus, and malignant transformation. In a study of perforated Meckel's diverticulum in adults, Dean et al. Found that 60% of patients were diagnosed with perforated appendicitis preoperatively, while only 13% were diagnosed with perforated Meckel's diverticulum. This may be due to the fact that Meckel's diverticulitis is often symptomatically indistinguishable from appendicitis, as the disease process is identical. The perforation of Meckel's diverticulum is either caused by foreign body due to irritation and pressure necrosis of the diverticulum valve, or spontaneous perforation due to progressive inflammation of Meckel's diverticulum valve, or as in our case, which produce peritonitis. Conclusion. Meckel's diverticulum complications are uncommon and challenge to diagnosis. Early diagnosis and timely operative intervention must occur in order to provide the best outcome for these patients. Spontaneous perforated Meckel's diverticulum often presents as acute abdomen, and its preoperative diagnosis is difficult. To patients with sudden abdominal pain, which mimics acute appendicitis, accompanied by a past medical history of bloody stool and chronic recurrent abdominal pain, perforated Meckel's diverticulum should be kept in mind as a differential diagnosis. Thank you, ma'am. Thank you, sir.
Okay, Amit.
Yes, sir.
Yeah. What are the most common symptoms which you can differentiate whether it is a Meckel's diverticulum or appendicitis? Is there any tool? It is a perforation. Otherwise, in a normal case, he must have complained of pain earlier also, but it was missed during the workup by any doctor. Okay, so is there any tool?
Sir,
if a patient comes to you with the symptoms of pain in the right iliac fossa, vomiting and all, so anything which you can keep in your mind?
Sir, appendicitis. Appendicitis.
if you are keeping in your mind that this is a young boy, as you said, and he may have some because diverticular type of thing, so can I go for some other workup for this patient?
It's a technetium 99M per technet scan that is being performed, sir.
It is not available everywhere, doctor. And some other things.
Sir, history bleeding PR must be considered.
Yeah. I wanted to know. And if bleeding is there, and you are saying it is not a rectal polyp or anything like in a child, then what you can go for? You are getting a bleeding per rectum, and your PR is normal, no polyp, rectal polyp is there. Then how you can confirm from where this bleeding is coming? Some simple tool. CT angiography can be done. Okay. Okay. Thank you.
Okay, thank you, Amit. Now,
Amit,
Dr. Sanjay sir wants.
Sir, want to ask you.
Okay, Amit.
Yes, Sanjay sir, go.
Patient had some pain abdomen, no? But like appendicitis, was there any recurrence of pain abdomen or inflammation in that case or not?
Sir, actually, he presented with 5 days history of pain abdomen only, sir, and with associated with vomiting and fever.
Okay. Did you ask the question whether he had pain abdomen or some such episodes previously or earlier in different times also?
Yes, sir. Yes, sir. Actually, sir, he didn't told me any previous history of pain abdomen intermittently also, sir. It just is told me only 5 days history and nothing else.
Oh, okay. It was an acute presentation.
Acute,
No?
yes, sir.
Okay.
Okay, now, Dr. Aju, are you there?
Yes, ma'am.
Yeah.
Okay. Yes, now continue from where you left.
Discussion was the point where he left.
Aju?
Aju, please speak something. Otherwise, we will think he's still not there. Yeah. Ma'am is sharing your screen now.
Ma'am, slides, please.
What
happened? Yeah.
Yes, this was your operative finding. You told about it.
Yeah, discussion was the point where he's left.
Yes, ma'am. Discussion and conclusion was left.
Yeah.
Start from discussion.
Slide is not visible. Aju, go ahead. Without slides, we can go ahead.
Yes, sir.
Okay, go ahead.
The internal hernia is per se very less incidence, less than 1%, and presentation of internal hernia as acute abdomen is also very less. And internal hernia presented with features of intestinal obstruction, it accounts for less than 5% of all the cases of intestinal obstruction. Our case was presented as acute intestinal obstruction, and intra-op it was found that internal hernia through transverse mesocolon, and there was no history of trauma and previous surgery.
Okay.
Therefore, it became very unusual because hernia through transverse mesocolon is mostly predisposed by either trauma or previous surgery. But in our patient, neither of it was present. Although internal herniation is a very less by incidence, but if there is internal hernia present and it is strangulated, then mortality is more than 50%. It was reported in here and there literatures and reviews. Therefore, management is very necessary, and unfortunately, we cannot diagnose it preoperatively. It is diagnosed mostly either during autopsy or exploration of acute abdomen. That's all, sir.
Okay, Anju, you completed.
Yes, sir.
As you were discussing about, this is the not most common cause of internal hernia. Most common cause of internal hernia is, most common type of internal hernia is?
Yes, sir. Sorry, sir.
The most common type
Hello.
of internal hernia is? The most commonly we used to get.
The most common cause of internal hernia is a paraduodenal or through the foramen of Winslow in the lesser sac.
Yes. Thank you very much. Very good answer. Okay. Sanjay sir.
Thank you, sir. Thank you, sir.
I have seen one hernia through diaphragm, which went to the, left chest cavity, and it presented as a obstruction. We had one case there. And apart from diaphragmatic hernia, it was seen. I have encountered such a case.
It was post-traumatic, sir, or in a child?
No, it was spontaneous and had no trauma at all.
Okay, Sumega ma'am.
Okay.
Yes, sir. Thank you so much.
We can shift to.
So we have now come to the end of the session.
Okay.
And thank you, sir,
Sumega.
for giving us so much time, sir.
Hello.
Sir is there, sir. Sumega ma'am, sir is there.
Yes, sir.
Sumega.
Yes, sir.
So I'm sure must be online by now, everyone. See the participants, we have the Jharkhand state chapter has honored you by accepting and listening to your deliberations. My humble request to you is to join the state chapter and join the Association of Surgeons of India. You see, I always give a simile right from my day one of career in the Association of Surgeons of India. I always say, if the rivers will say, what will I get if we join the ocean? The simple answer is that the ocean will not survive, but in turn, the river will also not be flooded. Because you are going to break the path of water cycle in the nature. So just like that, take it simple and join as early as possible so that you can reap all the harvest of association. So dear friends, I have repeatedly requested the organizers, the state chapter officials, that everybody should be a member of the ASI, because this is where we can say that we are from one fraternity. And I'm sure that in Hall B, a lot of participants, almost all of them had no ASI membership. So I will still request you, you are getting a lot of money. When I was intern, I used to get 325 rupees and my association fee was 250 rupees. But still I joined the association. So by that scale also, you are very rich. So please join the association and please be a part of the ocean, be a river, don't be a canal, don't be a stream, be a river. Well done. And well done, Arunima and the team, Dr. Sunil, Arunima, and well done the Daltonganj team for chairing this session. I was very happy when I found two giants of Daltonganj chairing this session. So that's very dear to me, you know.
We are honored, sir.
I really became very happy. And I told you right in the beginning that I am taking the back seat now, the EG chair, and watching from EG chair that things are going good. And so I'm feeling now today I'm feeling a grand old man, an elated person, very, very happy. But take it from me, every one of you have to still match my energy.
Sir, Definitely.
Thank you. Thank you very
Thank you,
much.
sir. Thank you, sir. Thank you, sir. Thank you.
Yes, Sumekha,
Thank
you
you,
can
Sumekha.
conclude the
Well
session.
done.
Yes, Sumekha, ma'am.
Thank you so much for your kind
Yes.
word. And we have the
How to go
certificate
to Hall A?
Dr. Anwar Nizam and Dr. Sanjay Kumar. Thank you, sir. Thank you so much for
Thank
chairing
you,
the
ma'am. Thank you,
session.
ma'am. Thank you, ma'am.
Yes. Thank you,
And
Dr. Anwar Nizam, and thank you, Dr. Sanjay, for chairing this session
Thank,
and being a part of
thank
this
you, ma'am. Thank
conference.
you.
Thank you.
No, thank you, ma'am. It
Yeah.
was a good beginning, ma'am.
Is it
With
is
your
it
efforts
is it
only.
is it the team in future? Arunima?
Definitely, sir. Definitely.
Is it the team in future?
Sir, I hope so.
Arunima, I think it's going
Arunima
to be
ma'am
the
should be
team of
there in
future.
every conference.
Yes, sir, I
Sir.
think
Very
that
good.
will be a good team.
I
Yes.
think this is the team of the future. Carry on.
Thank you, sir.
Okay,
Okay,
ma'am.
thank you very
Thank you,
much.
sir.
Bye
Thank
bye.
you, ma'am. Thank you.
Thank you.
Bye-bye.
I think we end the program of this hall, and all of you can join Hall A because there are
A.
some sessions going on over there. So, Sumekha,
Okay.
please end the session here, and Dr. Nizam and Dr. Sanjay Kumar, you can please join in Hall A.
Okay.
Okay,
Thank you,
see
ma'am.
you
Thank
then.
you.
Okay,
Okay.
thank you so
Okay.
much.
Bye-bye.
Thank you.
thank you, ma'am. And we can now end the session and we can join now Hall A. Thank you, sir. Thank you so much. Thank you, ma'am.